It's now my pleasure to introduce the moderators for tonight, Dr. Michael W. Brennan, a past president of the Academy, and Dr. Mildred M.G. Olivier from the Chicago Medical School of Rosalind Franklin University of Medicine and Science.
Hi, thank you so much, Michael, and too many Michaels on for tonight, but I certainly am it is a pleasure to really introduce you to Dr. Michael Brennan, who I had the pleasure of working with on the Haiti Task Force through the American Academy of Ophthalmology. One never knows where Michael is in the world because he really travels all over and has great experience and really talks about long-term collaborations with the host countries and also with disaster relief. So it really is, without any further ado, I'd like to welcome as my moderator, Dr. Michael Brennan.
Thanks, Mildred. It's always a good fortune to be a friend of Mildred's because she has amazing connections. I had the pleasure of working with the Academy on international activities for about 20 years. Started out in Pan America, actually, with the Pan Am organization. Then I got involved with some international non-governmental organizations doing reconstitution in Middle East medical societies, not just ophthalmology, but all the specialty societies in Iraq. Tried to do the same thing in Afghanistan and Libya with less success. Mildred and I did a good bit of work collaboratively in Haiti. Everyone should know right up front that I have really never been inside an eye on another continent, so I do mostly organizational development. And it's been a true pleasure. Happy to be called the International Envoy. I wanted to have a chance to speak with you about just some of the aspects of and to get you ready for the opportunities that you should know about and I hope you'll pursue. There is quite a variety of opportunity and responsibility and challenge from the humanitarian service side through disaster conflict. And then many of you might just be a globalist and want to go meet someone in another country, a fellow physician, and work with them. I'd like to briefly talk about some of the ground rules that I felt are critical for any volunteer, any globalist to respect. First of all, you need to sign in. You need to make sure that you're sponsoring an organization, and you need to really make sure that they have presented your credentials to an appropriate authority in another country. You wouldn't want someone practicing medicine here without a license. I always say there's no room for solicitation, whether it be for a corporate entity, for a religious affiliation, or for some other political aim. There's no room in volunteerism for solicitation. Certainly, obviously, sensitivity to culture is critical, and I always say that a second visit to a country makes a very big difference. Finally, respect the host authorities, the governmental authorities, the National Ophthalmology Organization, and any other organizations that are also serving the public interest. Sometimes there's competition, especially in disaster zones. Everybody wants their flag to be flying highest. So respect the interests of others, be genuine, be prepared, and be positive, and I think most of all, smile a lot. Friendliness in other countries goes a long way, even when you don't know the language. So I'll quickly introduce our first presenter and tell you that I've known Jennifer Staple Clark for a long time. In fact, we invited her to an Academy board meeting years ago, trying to encourage her to pursue a direct medical career and become an ophthalmologist. Fortunately, I think for the globe and for a lot of patients in many countries, Jennifer has pursued a non-ophthalmologist pathway, and she's been remarkably successful, and her success has translated into surgery for many and service for many volunteers like this audience. She is the founder of Unite for Sight, and it's a multi-pronged entity that does education, service, research, a vast variety of activities related to globalism. She received the John Kennedy New Frontier Award that's presented by the Kennedy Library Foundation and the Institute of Politics at Harvard. She is a mother and a busy lady at home, but she has really developed a remarkable entity that serves the young, the active practicing physician, and it integrates a wide variety of very professional speakers. So I'll not take her story away, and I'm proud and happy to introduce Jennifer Staple-Clark.
Thank you so much, Michael. Thank you so much, Michael, for your very kind introduction, and it's wonderful to be here with everyone electronically today. So I'll start by discussing responsible global engagement, and as Michael was sharing, the importance of supporting and assisting local physicians, local ophthalmologists in their own countries. And as I'll share as well about how UNITA for Sight operates, it's so critical to support those local doctors and help them to flourish and provide care for their own local patients. Only those local doctors know their local patients the best. So to begin, this is a photo of a patient who had a cataract surgery that was not done by UNITA for Sight, but was just done by a visiting short-term medical mission program that had been done in Honduras many years ago. And this is the outcome for that particular patient. And you can see here how the patient had completely lost his eye from the cataract surgery. And if we were to only look at that first image, we would think, okay, this patient had cataract surgery and presumably they have their sight restored. But it's only if you actually measure outcomes that you'll actually know that this particular patient had a very devastating outcome to the surgery due to a post-operative infection, and the doctors who provided the care left the country quickly after they provided the surgery. And those doctors who left probably never even realized the actual outcome for this particular patient. And this really highlights the difference between an output and an outcome. So if we were just thinking of the number of patients who received care, the number of patients who received cataract surgery, that would be the output. That would be that one patient that we had seen. But we have to look at the outcome because the outcome is so critical. Was it a sight restoring cataract surgery, or was it something that actually caused significant harm? UNITA for Sight came across this patient many years after he had received that unfortunate cataract surgery, and he had come to UNITA for Sight's partner eye clinic in Honduras, Zoe Eye Clinic, hoping that his eyesight could be restored, but unfortunately nothing could ultimately be done for that particular patient. But that critical difference between outputs and outcomes is always essential to be thinking about, that when you do a surgery, there needs to be, of course, post-operative care just as there is in the United States, and just coming in for a short-term intervention is not going to provide the necessary care for any patients. Those local physicians, the local ophthalmologists are the ones who need to be supported and to provide this type of care, and they are able to care for the patients on a daily, year-round basis. And similarly, if we think about outputs versus outcomes in a number of other contexts within global health, malaria nets, for example, many organizations discuss how many, and you'll see on their website, how many malaria nets they've distributed. But just distributing a malaria net does not mean that malaria is being reduced in any way. And so the difference between an output of the number of malaria nets being distributed versus an outcome of how many cases of malaria are being reduced is another very important thing to be thinking about. Many times malaria nets are distributed and actually used as you can see in this image, as things like fishing nets, and sometimes they're used to cover gardens, of course things that are not preventing malaria, soccer goals you can see in this image. So if you're just doing something based on outputs, you're not knowing whether something is actually making an effective impact in the field. And another example of this is play pumps. And it was around 2005 that people were very, very excited about this very new, innovative idea that a lot of people were talking about, including at the Clinton Global Initiative. It was the first Clinton Global Initiative that people were very excited about, this huge public-private partnership with play pumps. And the intent of play pumps was that children would spin on this merry-go-round. While they were having a joyful time on the merry-go-round, water would be pumping out of the ground and going into this big basin that you can see in this image behind the children. And that it would, the goal was to improve access to water for the community. And here you can see kind of the diagram of the theoretical plan process for what this play pump would be. And people were so excited about it because it seems new and innovative and different, and yeah, children can play and it can provide water for a community. But in reality, there are major issues with the play pumps. So first, many of them broke down and there was no one to fix them. Secondly, the kids didn't actually really enjoy playing on the play pump, so no one was using the play pump. But a lot of communities, actually, their access to water was removed. Their standard hand pump was actually removed from their community without any discussion with the community members, and play pump organization would just come in, remove the hand pump, their normal traditional hand pump, replace it with a play pump, and expect people to want to use this play pump because someone had thought of this idea that seemed innovative and creative. And the children were then not playing on the play pump, but instead the women, many times very elderly women actually, had to be the ones to then spin this big wheel around and around and around, just trying to get water for their family. So it becomes a very devastating, really sad situation for those community members. And here you can see the old women kind of spinning this big wheel, just trying to get water for their families. And here you can see in the image, this particular woman was saying, "From this, your arms start to hurt." And so it just was not an effective practice. But the main reason it wasn't effective was there was this, what was considered an innovative idea. The goal was to put play pumps in as many places as possible, focused again on outputs, not outcomes. They wanted just number of play pumps. How many play pumps can we get out there without measuring outcomes and thinking about whether this is actually improving access to water, which of course is really what should have been considered from the onset of the start of this project. So here you can see the image of the more traditional hand pumps that were typically removed from the communities and replaced by the play pumps. So play pumps, ultimately, there was a UNICEF evaluation of them in around 2007, which found that there were health issues. There was dizziness, children were falling off and hurting themselves, children were vomiting after spinning on this big wheel. And when the children were not available, it became the adult women, typically, who ended up needing to go using this big wheel, and they were actually embarrassed to be using it because it seemed like they were just playing around, especially when they were near a public road and visible. And really shockingly, 63% of the Zambia play pump sites reported that they were not consulted, presented with no technology choice, and that they preferred the previous hand pump that was removed. And again, this really highlights the importance of supporting and assisting local communities and local professionals. That someone who has some type of innovative idea or plan and is not from that particular community, they can never fully understand in any capacity what that local community actually needs or wants. And it's so important to have a collaboration and, most importantly, to listen to local community members and listen to local professionals. And there's a great organization called Kickstart, which is kind of the opposite of what we've just been describing, where they focus very heavily on outcomes. And they say we could base our claims of success on the number of pumps we've sold to date, but this tells us nothing about whether we are meeting our mission, which is helping people get out of poverty. To know this, we have to measure how much more money the buyers of our technologies earn as a result of owning them. So they collect a lot of data, and they're then able to determine that because of the technologies that they are selling to the community members, that there is the outcome of improving their ultimate income and moving them out of poverty. And similarly, Unite for Sight focuses very heavily on collaborating with local communities and focuses on outcomes. So as a pioneer of responsible healthcare delivery, UNITA for Sight serves, empowers, and mentors organizations and individuals to provide high-quality care and high-quality outcomes by supporting and assisting local ophthalmologists in specifically Ghana, Honduras, and India. And for all of the surgeries, and we've now, UNITA for Sight has supported the local ophthalmologists to provide now more than 100,000 sight-restoring surgeries in the past 12 years. And all of those surgeries are provided by the local doctors, and we have data on all of these surgeries that are provided. So we require preoperative data and postoperative data of all of the patients receiving care, and we do data analysis on all of those surgeries. So we know that, yes, indeed, this was not just a cataract surgery. It wasn't just an output of a number. It was an outcome of a sight-restoring cataract surgery, that it had this positive outcome and the patient's sight was fully restored. And we also do a lot of other work with data, such as we have a lot of wonderful volunteers, many medical students, for example, as well as ophthalmology residents and ophthalmologists who travel abroad to support and assist the local doctors who are providing this care on a daily, year-round basis. And many of those volunteers pursue IRB-approved research studies that has further assessed patient barriers to care for the hardest to reach patients, so that even though those local doctors know so much about the local situation with different patients and so much about their different barriers to care, they don't know all of the barriers that are impacting a particular community or particular individuals. So these research studies help to delve further into that and help those local doctors to develop additional strategies to reach those hardest to reach patients. This is an image of Dr. Seth Nwanyanwu, who is a phenomenal local ophthalmologist in Ghana. He has been, since 2004, the only Ghanaian ophthalmologist providing care for the entire northern region of Ghana, and that northern region spans almost half of the country, and it's 2 million people. So he is the one ophthalmologist for 2 million people in that area of Ghana. And before UNITA for Sight started working with him and supporting him, he was not able to provide any cataract surgeries because he didn't have the equipment to do so at the time, and this is back 2004, 2005. And he also, the patients weren't able to afford the cataract surgery, which was at the time about $35, and now it's a little bit higher in Ghana. And UNITA for Sight then partnered with him, and he went from providing 0 surgeries in the northern region to the first year was about 350 or so surgeries that we were able to help him, support him to provide. And then by 2012, and it kept increasing, 2012, in a single year, it was just Dr. Nwanyanwu who provided more than 4,200 sight-restoring surgeries in that 1 year. And it's just such a great example of how support to a local incredible ophthalmologist can just enable them to fly and flourish so much that he's developed these incredible strategies to reach those hardest to reach patients, eliminate their barriers to care, and provide surgeries and also provide follow-up to those patients. So UNITA for Sight works in 3 different countries, Ghana, Honduras, and India. And I'll also mention another incredible example of a local social entrepreneur and eye care professional whose name is Robert Dolo. And he had been an ophthalmic nurse with UNITA for Sight's partner eye clinic in Ghana called Crystal Eye Clinic from 2006 to 2009. And he, as an ophthalmic nurse, decided that he wanted to become a cataract surgeon. So not an ophthalmologist, but a cataract surgeon. So he went to training in the Gambia with Sight Savers organization, had a specific training program. And he then returned to his native Liberia and has been very involved with the Ministry of Health there and one of the only eye care professionals in the country of Liberia. And he has developed a phenomenal eye clinic there in Liberia and now actually is developing a second eye clinic, and as well as training additional ophthalmic nurses. He now has an accredited program, so it's not just the Gambia that's in West Africa providing this type of training, but now he has an accredited program there in Liberia as well. So another example of just a phenomenal local social entrepreneur and local medical professional who's able to do incredible things. And UNITA for Sight doesn't work directly with him, but has supported him along the way in a variety of ways. So UNITA for Sight's work is very much within local communities that don't otherwise have access and can't otherwise afford the care. So oftentimes very rural locations as well as urban locations and refugee camps as well. So the process involves the local eye clinic sends an ophthalmic nurse and an optometrist into villages or refugee camps, and they provide eye care on site, whatever can be provided on site, whether it's a diagnosis exam, glasses, or medication, and then anyone who needs more advanced care is transported back to the local clinic where the local ophthalmologist is stationed, and that can be anywhere from about 1 to 8 hours away from their village. And as I mentioned, we have a lot of Unite for Sight volunteers who travel abroad to support and assist these incredible local ophthalmic nurses, optometrists, and ophthalmologists in the field as they are providing care. And the local eye care professionals provide eye health education. That's how these outreaches begin. And then they do their exams and diagnosis. And the local doctors are always the ones providing all of the medical care, the medications, and the eyeglasses as needed. And then the local ophthalmologist is the one who provides the advanced ophthalmic needs, such as surgery. And I know I'm out of time now, so I'll leave it at that. But so through this process of collaborating with and directly supporting local ophthalmologists, Unite for Sight has provided eye care for more than 2.5 million people throughout the world, and that includes more than 100,000 sight restoring surgeries. So thank you so much.
Great. There was a lot of information, and certainly, Jennifer, and again, just I understand what Mike's saying about it's a good thing you went into this area. I'm going to encourage everybody who's on the call, the medical students who are on, to ask any questions that they might have. In the interim, I'll ask you just what made you sort of go in this direction to set up something like this that now medical students can go to.
Oh, sorry, I had put myself on mute. You had asked what programs medical students can participate in?
Yes.
Yes. So Unite for Sight's programs, actually here we have my next slide. So we have hands-on responsible ophthalmology engagement. So where medical students can travel abroad to support and assist those local doctors, help with everything from patient intake and visual acuity testing to sitting with the local eye doctors to learn about the diagnosis and examination process. And there's so many different pathologies that are not seen in the United States, for example, that the local doctors are so skilled at just using an ophthalmoscope, for example, to diagnose. So it's an incredible learning opportunity to just spend time with those local doctors. And then the medical student volunteers also assist with things like distributing medication and glasses that are prescribed by the local doctors, also having the opportunity to observe the sight-restoring cataract surgeries that are provided by the local ophthalmologists as well. So it's very much a hands-on engagement to support the local doctors. And it's because of these volunteers that the local doctors can see so many patients on a daily basis. So typically they'll go to a village and we'll actually see sometimes 300, even 400 or 500 patients with a very small team of eye care professionals, because those eye care professionals can focus on what they do best, which is the examining and the diagnosing and treating. And the volunteers can help with the other aspects, such as I described, the visual acuity testing and patient intake and all of those pieces that enable kind of the train to run this downstream as each patient goes kind of from one station to the next station. And ultimately, the end of the day, and suddenly everyone has seen 500 people and provided them with care that they wouldn't have otherwise been able to access or afford. And then medical students also have the opportunity, as I mentioned, to do IRB-approved research studies. Those research studies are designed by, or the concept is developed by the local doctor. So the local doctor says, we have not been seeing any children, for example, in an outreach maybe in this particular village or this particular region. We want to understand why that is occurring. Why are children not being brought by the adults to receive eye care? The eye care is being provided in their village and they're just not coming. So then from that concept provided by the local doctors, Unite for Sight works with those volunteers who want to do a research study, designs it in collaboration with the local doctors. They get their IRB approval from their their own university. They travel abroad to Ghana, for example, and they can then implement this research study, collect the data, submit it back to Unite for Sight, which then we analyze it along with the volunteer, and that's submitted to the local doctor. So it's this wonderful opportunity for the local doctors to learn more about their own communities and be able to identify strategies to reach more patients.
And so one of the questions has to do, are you planning to expand Unite for Sight to other countries?
That's a great question, and something actually we hear a lot. People are always asking, are you going to more places? And we have been working with Dr. Nwanyanwu, for example, since 2004 or 2005, and Dr. James Clark, who's another ophthalmologist in Ghana, since 2004. And we have been working with them basically every day for all of these many years, supporting them as they're building up their own capacity, going from 200 surgeries a year to 4,000 surgeries a year. So we are very invested in the particular clinics that we're already working with and supporting them as they are able to provide so much care in their communities. So we have not in recent years expanded to any additional clinics or additional countries because we really want to be fully invested in those partners that we're already engaged with. And we also know we can't be everywhere and do everything because it's just not possible for a single organization to do everywhere. So that's what really brings us then to the Unite for Sight Global Health and Innovation Conference, which is the world's largest global health conference and social entrepreneurship conference, bringing together 2,000 people from all 50 states and 50 countries. And it's this exchange of ideas across all different disciplines. And we want to bring together people who have effective strategies and great ideas and focused on responsible global engagement. And they learn from each other and can further boost their own work and then reach so many places throughout the world. So we really like to help that collaboration and innovation through the conference.
Well, thank you again, Jennifer, for all the information that you gave us. I think this is really great for the medical students. And at the end, if we have more time, I certainly would like to entertain some of the other questions that will be popping up. But it is really my pleasure. It is really my pleasure to introduce our next speaker, which is somebody I've known through the Rad Venable Program and who also trained as a vitreoretinal surgeon here in the Chicago area where I am, and that is Dr. Kristen Nwanyanwu, and she's an assistant professor at Yale University. As I said before, her subspecialty is vitreoretinal surgery, and she splits her time between health equity research in diabetic retinopathy as well as seeing patients. I tell you, she is one of the most energetic people that I know, and I think tonight we'll certainly enjoy her presentation and her enthusiasm and the things that she's now doing at Yale. And it's amazing that both of you are at the same place, so I think that's great for us. So without any further ado, Kristen, please take over.
Hello, everyone. It was so awesome to hear Jennifer's just platform of her organization. She's just phenomenal. And I know a lot of you guys out there are probably saying #goals, right? I want to be just like her, which is fantastic. But just in case you can't be like Jennifer Staples Clark, because I think there's only one, there are other things that you can do in your local community until you get the opportunity to do some of the amazing global work that she's been able to do. So my job today is to discuss with you local community outreach in ophthalmology. So what we're going to do is go through the problem. You all are fortunate because recently there was a big report by the National Academy of Sciences about population health in eyes. And what it really does is put the work that ophthalmologists have been doing for years into context. And so it really talks to us about how we've been engaging community, what it looks like to engage community, and put that all together. And so what we'll talk about is the problem, which has been outlaid really nicely, so I'll go through that with you all. And then we'll talk about being part of the solution and doing so responsibly and following some of the guidelines that actually Ms. Staples Clark has already stated. Okay, so the problem. All right, so vision and eye problems are increasing. This makes sense. America is getting older. We're becoming more diverse. So 90 million Americans over 40 have vision and eye problems. So that's quite a bit. That's more than 3 in 5. And this is all comers vision problems. So data says that by 2050, without effective intervention, a lot of visual impairment, sources of visual impairment will be increased. So that's diabetic retinopathy increasing 72%, cataracts 87%, glaucoma 100%, age-related macular degeneration 100%, and then vision impairment and blindness 150%. So we need you. If you're considering a career in ophthalmology, you have some job stability here. So also the cost of problems in vision. So it's supposed to increase 157%, which is really exact. But what we're talking about is billions of dollars, $373 billion. And when you think about healthcare and this as a sliver of healthcare and what we are doing in America with costs, I don't know if you are following the Bezos stuff that's going on with really trying to figure out what to do with healthcare. This is something that's going to be with us to stay. And as eye care providers, we really need to be at the forefront of this. And vision loss touches every part of people's lives. Sometimes in medical school, eyes can be put off to the side, and it's really important to note that the eyes are interconnected with the rest of the body. It's important not to think of the eye in a silo, but to think of the eye as part of the entire body. And so this really demonstrates that. So people with vision loss, and these are actually associations, so some chicken and the egg is going here, right? So type 2 diabetes, you all have heard about retinopathy before, depression as well. So what happens is a lot of our patients actually, because they can't see, are at risk for depression, and we also have to be aware of that. Stroke and the vision loss that comes from that, hearing loss as well, and also chronic kidney disease. Other things, so vision loss is also related to isolation. If you can imagine, if you're not seeing well, you can't get out, it's difficult to get around, you may become isolated. Also balance problems. If you've ever, had a problem with one eye or had something in your contact and tried to do something that requires balance or requires depth perception, it's really important to have vision in that. Falls and fall-related injuries, there are some cataract studies that you can PubMed about cataracts and falls. And so you really are valuable in helping quality of life in that regard. And then risk of early death. And a lot of times, the eye can be a sign of really advanced disease. If you look, there's some studies about advanced diabetic retinopathy and mortality. So we're not only talking about morbidity, we're talking about mortality as well. So what does it mean to be a part of the solution? So this is just what it takes to screen for eye disease in your local community. And some of you all, a lot of you all probably have done this before. So things that you know how to do are included. So you know how to take a history, which is very important, past medical history, which will inform what you're looking for in eye disease, past ocular history, which you can learn, surgeries and other things that have, and ocular events that have happened in participants' lives. And then your exam. So that's taking the visual acuity, intraocular pressure, slit lamp examination, and fundus examination. And what we'll walk through here is what it looks like in the clinic and some of the clinics you all have visited. And then we'll also look at what it looks like when you're out in the field with a community. So I have a toddler. So this is Sesame Street on your left here. And there's a fantastic episode of Sesame Street where the prince is actually not seeing well, and he needs glasses. So he has to go see Dr. Judy, who's an ophthalmologist, who helps him to see so he can ask the prince to marry him, and he will only marry her after she finishes law school. Love Sesame Street. So this is a fluoropter, this is an examining, this is checking visual acuity in the clinic. But in the community, we use what's on the right, which is a near card. And so that's because to measure visual acuity, right, you think about it 20/20, right, you see at 20 feet what most people see at 20 feet, or 20/40 or 20/60, and that's how that works. But it's really hard to do in some place that it's not correctly designed. So we use a near card, which has a 14-inch distance that is calibrated so that you can test visual acuity in that way. So slit lamp examination, you saw a really good picture of this in Ms. Stable-Clark's slides before this, but we use the portable. And so portable is a similar instrument that you'll see on the right that is handheld but still has some of the capabilities and the necessary narrowing of the beam and the slit functions that are really important to be able to assess. Great. And then in the clinic, you'll see indirect or direct ophthalmoscopy, and usually it's an indirect like on your left. But a lot of times in the field, we'll use the direct, which is presented there. Now, what's nice is that technology is improving and advancing, and there's some mobile phone technology that is helping us to be able to do a little bit better job of this in other places. So say you're really into this and you'd like to get involved. So some of these programs, I believe, still exist. So when I was a medical student, I got involved in community screenings through the Student Sight Savers program, where we were given some materials and we offered screenings at local health fairs and otherwise. Other ways to get involved is to partner with local organizations. Lions clubs and otherwise really are interested in having opportunities for their community members to engage with eye care in a way that is easy and accessible to them. Lastly, so partnering with a free clinic. So actually at Yale, we are building a relationship with one of the clinics here to treat some of their patients, or excuse me, to see some of their patients that may not otherwise be able to have eye care or even eye screening or assessments. And so here, that is some of the undocumented populations and otherwise that just don't have access. And so trying to figure out how to extend that arm of care to them. And so what's really important, though, when you're setting up these systems is that you have to figure out what to do if you find something. And so it's really often to say, oh, look, just like what Ms. Stable-Clark was saying, oh, look, we found X, or we looked at, 300 eyes. But then when someone had a problem, what did you do? And what were you able to do for them? Because it's not enough just to find disease. You have to make sure that you have an appropriate outlet that's properly funded to treat someone when you find something. So I want you all to notice these references. So these are the references for that great report. It's really long, but the first part has a summary of things. So I know you all are very busy, so the summary actually works great. And some resources from Prevent Blindness and the CDC about what blindness looks like in the United States and going forward, and where you will fit in as our next generation of ophthalmologists. So this is my contact information. Feel free to email me if you want to talk about any of these things further, and I'll take any questions you have.
Great. Well, thank you so much, Kristen. I think, this particular webinar is exactly about what you're talking about, having medical students get involved in their local or globally, as Jennifer talked about. And I think both of you have given the individual medical students ways of kind of getting in there and doing these types of local communities. You did talk about areas where medical students could go and get involved. I wondered if you maybe could say something as technology is getting better and better, how that perhaps, has helped you in your screening efforts.
So technology is really important in diabetic retinopathy. Telemedicine has been used to evaluate diabetic retinopathy for quite some time. I think the frontier, and the frontier where some of my research is in trying to decrease the cost point from that. That's not just the MBA, that's also other important things that go with that. So if you could think about it, a really nice tabletop camera probably costs about $25,000. And the reimbursement for one funded photo is about $29. And so it's pretty cost prohibitive to put a camera in places that don't have high volume and in places that aren't traditionally for ophthalmic care. But what is happening with technology is that we now have the capability to use mobile phone technology, and there's so many wonderful apps and additions. So what we're trying to do and shake out in the literature and otherwise is which one of these are going to be really helpful for us in a non-mydriatic eye or an eye that's not dilated, so that we can actually start to really use and improve our access by using technology. And so what we're looking at are how to use those technologies and how to put them in the hands of people that don't necessarily have medical degrees to be able to give us access to more information. There are about, for diabetic retinopathy in particular, there's the 40% that we always talk about that don't get the screening that they need, and we worry about them because that's usually where the blindness comes from. So trying to really use technology to our advantage is really, really important.
This is Mike. I wanted to make a comment, and Mildred, this does not apply to you, it applies to me. The advances in technology are captured and demonstrated so much more actively and facilely by the next generation. The older ophthalmologist isn't able to keep up with technology. This is where the medical students and our current residents have a big advantage in making technology work.
I would agree with that. I was just giving a talk at the University of Michigan, and one of the residents there has created one of these adapters for mobile phones and is working on that. Was doing fellowship interviews, and the residents are actually using 20 diopter lens and a mobile phone with the indirect to take video, so video ophthalmoscopy. And these are people that are in training, which is so awesome. It's a wonderful, wonderful time to be an ophthalmologist. It's a wonderful, wonderful time to be a physician. And for the next generation, the technology generation, it's just going to get better.
Great. What would you, I think between Jennifer and you, Kristen, what would you tell medical students in terms of if they want to get involved, how they can do that in their communities? Hello?
I don't mind starting. So I think the most important quality of someone that wants to get involved when they don't have anything yet established is persistence. You have to really want to do something if you're creating something where something doesn't exist. And it's also to find good mentorship and to really engage the community. I think it's very easy to stay in your med school bubble because you have so many things to do. But if you find something that you're passionate about, the community members will see that passion and will help facilitate whatever your vision is. But to be able to do that, you have to be able to fully articulate that and plan appropriately and use your resources. So I think it's definitely possible from scratch, but you'll need community engagement and to be out in the community, and you'll also need mentorship from wonderful people like Dr. Olivier and otherwise that really know what they're doing and really know how to get things done.
Well, I think mentorship is very important. That's what got me into ophthalmology, by being exposed and sometimes even into my subspecialty by having many mentors. Everybody needs many mentors, but certainly. Jennifer, did you want to say something?
Yes, I agree with everything that Kristen had said. And on the international front, I think the most important thing is to not go in with the expectation that you're going to go somewhere and make such a big difference and do it on your own. It's so critical to support and assist those local doctors. And there are so many doctors throughout the world who would love to have that type of support and assistance. And doing something through kind of an established program of some sort helps a lot, so that you're traveling abroad and you're already trained in cultural humility and cultural competency and things that you might have had some exposure to in medical school to some capacity, but you never fully have that full comprehension until you're actually being trained for a particular location in a particular community, because every community is different and every physician that you might be working with is different throughout the world. So really important to identify how you best can support and assist the local doctors.
Yeah, and I'm sure that Dr. Brennan would agree. I mean, I think when I go somewhere, it's always about what I can also learn. It's an exchange between the host country and yourself learning. Sometimes when we're here in the United States, we have so much technology by which we use, but when you're out there, you really have to kind of go back to the basics and the clinical, and how does somebody under those situations really still give high-quality care, as you have demonstrated, and some of the doctors you've worked with in the areas where you have your clinics. And I think that's important. And also I think here in the United States with what Kristen is doing, being in your local community, where you also find that there's huge areas of disparity as well, and people still going blind in a place where we have a lot of technology, and we should be able to help.
Mm-hmm. Yeah.
I'd put in a plug for Jennifer's April meeting, the Global Health and Innovation Conference, because if a medical student wants to make some connections, there's a fabulous audience there. It's a wide variety of presenters and attendees from many disciplines in medicine, not just ophthalmology, a lot of public health for sure. And it's a great program at Yale in April, and then you can meet both of our panelists.
Yep.
Yeah, that would be great. Well, I know we're sort of winding down, and I would like to say that, and perhaps Michael would like to say more about it, but, these webinars we've been able to do them because of grant support and donations that people have given, and we're really excited about the diversity of individuals that we have and the amount of medical students that we have on here, and I think that's great. But I really want to thank Jennifer Staple-Clark and Dr. Kristen Nwanyanwu, as I love to say her name, for their time this evening. And there's just so much information. And, this is one of the series of another series that we have. So I will hand it back to Michael so he can sort of talk about the webinars that we have coming up as well. And if we find that any of you have additional questions, you could still sort of put them on there. And if we have time, our presenters will be happy to answer them.
Sure. Thank you, Dr. Olivier, and thank you, Dr. Brennan. The next webinar in the series will be on the topic of preparing for the match, and it's set for Thursday, March 29th at 8:30 p.m. Eastern Time. A link to register for this webinar is on the medical student page at aao.org. As Dr. Olivier said, I'll leave the platform open for just a bit longer, as long as the presenters are okay staying on. We'll probably give it about maybe 10 more minutes. If anybody has questions, go ahead and type them into that chat box. Looks like a couple of people are typing right now, so I'll let Mildred, if you want to handle the chat box and pose those questions as they come in, and then as we get closer, I'll let you know when we need to close down.
Okay, great. So I guess maybe Jennifer, you could, I know we posted it on there, but maybe you can just verbally repeat. People are really excited about your innovation conference, so maybe you can let them know what it's called again. And I think it's posted up there, but they're asking again the dates as well.
Yeah, so it's the Unite for Sight Global Health and Innovation Conference. So if you go to Unite for Sight's website, which is uniteforsight.org, you'll see a section that says conference. Or you can go directly to it as uniteforsight.org/conference. So it's April 14th and 15th, 2018, so coming up quickly, and it's at Yale University. We also have abstract opportunities. So several of them, the abstract opportunities already closed, more on kind of data research opportunities. Those abstract deadlines happen in October. But we are still accepting abstracts for what we call social impact labs, where people who have interesting, innovative ideas, whether it's in the brainstorming or early implementation stage, present a pitch at the conference and receive guidance and mentoring and advice from expert panelists. So it's a really great opportunity to present an idea in whatever field it might be. So if anyone has any ideas that they're interested in presenting, you'll see that in the Apply to Present section, and it's called the Social Impact Pitch. So you can see all the instructions there. But we also have a lot of people who just attend and don't present.
Yeah, and we have, I think since we're talking about hopefully opportunities, certainly the Rad Venable through the National Medical Association has an abstract. You can submit abstracts and maybe come to the meeting as well and get to know other students and residents and fellows and chairs even. And the American Academy of Ophthalmology we now have a program really to expose people to ophthalmology and hopefully have them become an ophthalmologist. And that's our Minority Ophthalmology Mentoring Program. And, we're really excited about people joining and going to the annual meeting and learning more and being mentored. So those are great. So there's a question for, I believe, for Kristen. What are some of the emerging or cutting-edge technologies that are implemented? Well, actually, perhaps both of you, they're asking Jennifer or Kristen, I think, about what are some of the things that we can use when we're off-site and not in our clinics.
So in terms of, for UNITA for Sites partner clinics, there are a lot of different technologies, innovative ideas out there, but the partner clinics that we work with actually find that the most important strategies are actually ways to reduce barriers to care and not in the technology that they're using. So they are able to diagnose so much more than ophthalmologists in the U.S. are trained to do. They're trained to do so much with just a basic ophthalmoscope. So they can do a lot with that. And then similarly for cataract surgeries, most of our partner clinics do not do phaco, but actually do small incision cataract surgery. And we also have a lot of ophthalmologist volunteers who travel abroad, don't know small incision cataract surgery, and are trained and learn it from the local doctors. And the reason that phaco, even though it's more of an emerging or advanced, or considered more of an advanced technology, but it doesn't often work as well because so many of the cataracts that the local doctors are seeing in Ghana, for example, they're so dense that the phaco process just doesn't work. It doesn't have the same level of outcome that is seen in the United States. So sometimes even what might be considered more basic technology can be equally or more effective in particular situations.
Great. Now, some people are asking just in general, and maybe Mike, I don't know if you can kind of put this up, but about the Academies program, maybe we can, it is on the medical student section of the American Academy of Ophthalmology's website for students to go there and sign up. That's where we actually talk about some of these webinars. So I think in that same section, is that right, Michael?
Yes, and I think I'd expand on that a little bit. The Academy also has a dual volunteer registry. One is for places to go, and you can look at a wide variety of places and organizations that sponsor or that accept volunteers. And then the other one is an opportunity to sort of pick your clinical dimensions, what sort of subspecialty you might want to pursue, and it'll offer some volunteer opportunities that way. Now, for a medical student, I think it would be the organization. Then you want to talk with a mentor, someone in your university ophthalmology program, about how you could get affiliated with that organization in a country that you might want to, or you might want to volunteer because you've got language, maybe you've got a cultural connection from your heritage. But the Academy has a lot of opportunities on the website.
And I would I'd like to put a plug in for the Rad Venable Program. It was really, really fantastic for me, and I actually went through it all the way from actually residency through fellowship, and then now I'll be moderating some of the panels at that ophthalmology section, the National Medical Association. So if you have any interest, it's fantastic. I really got to have just great access to some of the leaders in the field and encouragement from them, and I'm doing the work that I'm doing. Definitely a large part of that was interacting with them and understanding the nuances of what it means to be an ophthalmologist and how to navigate my career. So I'm forever grateful for that too. So if you have any interest, the Rad Venable Program is fantastic as well.
So Michael, Rhea has put on there the website and the links for individuals to go to the Global Ophthalmology or to the medical student section. You know, I think perhaps for you, Kristen, and certainly Michael Brennan can, you know, somebody is very curious about how you decided to go into ophthalmology or even retina for you.
Oh, yeah, sure. So ophthalmology was the only thing I wanted to do in the middle of the night. So I really loved it. I wanted to stay late. I taught all my classmates the cranial nerves. For me, I realized that I'm a very visual person. So ophthalmology is one of the few fields where you actually see what's happening and you diagnose through looking. We don't use a lot of laboratory tests. We do when we need them, but a lot of it is visual. And so I realized that I was that kind of person. It's also one of the few fields that you are able to diagnose a problem and then fix it yourself. There are a lot of fields where you have to send it to a surgeon, but you can be the medical person. You can figure out what's happening, and then you can also do the surgery as well. Also, ophthalmology gives you a lot of flexibility in terms of what you'd like to do. I also wasn't a fan of rounds in the hospital and those other things. I really like the clinic. I like the long-term relationships that I built with patients, and I like doing surgery. And so ophthalmology allowed me to spend a good quality time with patients in the clinic, see them year after year, take them through difficult periods, and then keep following them up. And then also to perform really complex, delicate surgeries. Vitreoretinal surgery came to me because I actually like systemic disease, but I wasn't interested in managing it. And so vitreoretinal surgery and retina is a way to see that and discuss those things, but then to be able to intervene in a meaningful way in ophthalmic surgery. And when I was a resident, I saw vitreoretinal surgery, and I said to myself, somebody has to teach me how to do that. And I was fortunate enough to be able to do that, and I went along to fellowship training. And then in terms of my career path in academia, I have a history of being an activist. So I was an activist in college, and access to education was where I did my work there. So access to eye care made sense to me because I fell in love with the eye. And so access to eye care for diabetic retinopathy is the work that I do now, and my position now in academia allows me to think through innovative solutions to those problems and to really contribute to the field that has given me so much in my career.
And at the end of the day, as you suggested and one can hear in your voice, it's really about the passion. What, you know, you want to get up and you want to go to work, and it doesn't, you know, it's not a job anymore. And I want to put a plug in for our previous webinars as well, because it did talk a lot about the different aspects of ophthalmology. I could do academia, research, so I would, and that is on the medical student section. So I think for a lot of the people that are on the call, it would behoove them to kind of go back and listen to that, because it was really a great session with perhaps factors that help in deciding what kind of ophthalmology, which programs to apply, you know, that you might need a mentor. Michael, do you want to say anything
about?
Yes,
I do. Okay. I want to go back to the global scene just a little bit, because whether you want to operate abroad or whether you want to teach abroad, the opportunity to meet our colleagues and their patients in other countries is just fantastic. And I didn't even really want to be a doctor. I wanted to be an astronaut. Now I just like to go around the world and meet people. And I just want to go around the world and meet people in other countries. And ophthalmology gives you, I think, a little more latitude schedule-wise than many other specialties. I didn't have the patience to be an internist for sure.